In any modern clinical intervention, the primary engineering challenge is a single objective: optimizing the therapeutic window. This requires maximizing the physical or radioactive impact directly on the targeted pathology. At the same time, the intervention must strictly preserve the biological and structural integrity of the surrounding tissues. Legacy standards of care often hit a hard limit, where pushing for increased target impact guarantees unacceptable collateral systemic strain. Breaking past these limits to find a superior balance of impact and preservation is a core metric for clinical success. Today, we are analyzing raw clinical efficacy data from two distinct, highly advanced fronts of targeted medicine. First, we examine peptide receptor radiotherapy for neuroendocrine tumors. Second, we look at the localized mechanical dynamics of intracorporeal lithotripsy for urological stones. By directly comparing legacy standards against two novel modalities, we can see exactly how the latest data shifts the boundaries of clinical efficiency. The performance deltas in this comparative data provide the definition of clinical advancement. We begin with a study by Quekeboom and colleagues, which tested the somatostatin analogue lutetium-177 octreotide against the standard indium-111 octreotide in patients with receptor-positive tumors. This line graph plots plasma radioactivity over time. Notice that by the end of the 24-hour timeline, the plasma radioactivity trajectories between the two modalities are nearly identical. However, this bar graph detailing urinary excretion shows a stark contrast between the two interventions. The data specifies that lutetium-177 octreotide shows a significantly lower average excretion of only 64% after 24 hours. This lower excretion metric indicates that the newer drug undergoes prolonged retention within the patient's body. That prolonged retention is the baseline prerequisite for delivering more concentrated radiation doses directly to the tumor site. We can trace that concentrated dose by examining the specific tissue uptake ratios comparing the two radiopharmaceuticals. This scatter plot displays the ratios across organs. The background uptake in critical filtering organs, liver, spleen, and kidneys, remains comparable between both drugs. The divergence occurs at the tumor sites, where lutetium-177 octreotide achieves a 3- to 4-fold higher uptake in 4 out of 5 tumors. These mathematical ratios are corroborated by clinical scintigraphy results, which show dark, highly visible visualization of the tumor sites absorbing the lutetium analog. The primary dose-limiting factor in this therapy is radiation toxicity to the kidneys. This kidney dose limit is successfully mitigated by a mean of 47% through a strategic co-infusion of amino acids during the treatment. Achieving 3 to 4 times higher tumor uptake while simultaneously reducing kidney toxicity by nearly half expands the therapeutic window, particularly for smaller, harder-to-treat tumors. We see a similar mechanical optimization when we transition from systemic molecular radiotherapy to the physical dynamics of intracorporeal stone fragmentation. In urology, the nanoelectric pulse lithotrieter, or NPL, has emerged as an advanced challenger to the current holmium laser standard. Bench model efficiency data comparing the smaller probes of both devices highlights a clear operational gap. Using a 2.0 French probe, the NPL fragmented bagostones at a rate of 86 milligrams per minute, contrasted with 52 milligrams per minute for the 200 millimeter laser fiber. This efficiency delta scales proportionally, even when testing the larger 3.6 French NPL and 365 millimeter laser probes. The nanosecond electrical discharge mechanism transfers disruptive energy into the stone much more efficiently than thermal laser ablation. Sheer fragmentation speed is only one metric. We also have to evaluate the physical mechanism of the failure. The NPL produces a higher yield of 1 to 2 millimeter fragments. The holmium laser, by contrast, primarily generates sub-millimeter dust, changing how clearance is physically managed by the surgeon. These energy tools also have a direct physical impact on the flexible ureteroscope itself. The NPL preserves superior ureteroscope deflection, allowing the clinician to navigate tight anatomical angles more easily. Critical irrigation flow is also maintained at higher rates, measured at 100 centimeters with normal saline, compared to the laser fiber. For the operating clinician, the NPL ensures critical physical maneuverability and visibility are not sacrificed in the pursuit of higher fragmentation power. The clinical findings from both radiopharmaceutical trials and urological surgical interventions reveal a clear pattern. Despite being entirely different fields, both modalities share a common engineering objective: engineering higher affinity and more efficient localized energy delivery leads to measurable improvements in primary clinical outcomes. These gains in target impact are achieved while simultaneously preserving the structural and biological integrity of the patient. Whether modifying an octreotide C-terminal for better receptor binding or utilizing nanosecond electrical discharges instead of lasers, intelligent precision outpaces brute force. Thank you for analyzing the raw data with us today. Please like the video and subscribe for more deep dive analyses into clinical efficacy data. We'd like to introduce our sponsor, Synestex Systems LLC, and founder Shane Persinger, who brought today's analysis to the channel. The data dictates that clinicians must constantly reevaluate and look beyond the complacency of the legacy standard of care.